Next, let's talk about gout. Now, gout, I'm sure you're going to get questions on gout. So when it comes to gout, right, it's basically when somebody's got too much uric acid in your body, and the uric acid is going to get deposited in your joints and different places and cause problems, right? In your joints, you're going to have gouty arthritis. You can form stones in your kidneys. You can also form tophi in different parts of your skin. So when, on a clinical aspect, when somebody comes in, right, when would you think of, okay, does this patient have gout, right? What would alarm you? What is the most common joint to get affected because of gout? Big toe, right, which is metatarsophalangeal joint, and when that gets inflamed and big, we call that podagra. So that's your classic presentation when it comes to acute gout. But sometimes you can also come with an acute big swelling of your knee. One red hot joint can be one presentation as well. Whenever you have any single joint that is red hot and painful, you always have to rule out septic arthritis. So whenever it's a large joint, then you always need to tap that joint because you want to rule out infection. So when you tap it, what is the cutoff of WBC is to say, hey, this is most likely an infection. It needs to be greater than how much WBC count?
2,000.
WBC count for septic arthritis?
Oh no, 50.
50,000. More than 50,000 is septic arthritis. When it comes to gout, what is the white count?
10 to 50.
It can be above 2,000, but it can go all the way even higher than 100,000. So it could also, be more than 50,000, right? Just like your septic arthritis. So the important thing though, in order for you to diagnose it, you need to show the presence of needle-shaped crystals. The needle-shaped crystals are going to be present, and that's how you're going to diagnose gout. Okay. Now, why does this needle-shaped crystals actually cause problem? Why does it cause arthritis? Is it because the needles are going to go poke you in the joint and cause pain? Sounds like a good theory, right? Well, it actually goes into the joint. The synovium has macrophages. The macrophages are going to eat all these crystals, which is formed by monosodium urate, right? Monosodium urate crystals. Once it chews it up, it actually releases something called interleukin-1 beta. Now that's important. I want you to remember interleukin-1 beta. That interleukin-1 beta is going to cause a lot of vasodilation and attract a lot of neutrophils to come in there and cause more inflammation. And that's how the whole joint is going to get inflamed and cause a problem. That's gout. And another important thing, because gout and pseudo-gout, you're going to have to kind of differentiate. As a key feature, gout typically never lasts more than 3 weeks, an acute episode. Okay? Never lasts more than 3 weeks. 3 weeks is an important number to remember, and pretty much all the time is going to affect your big toe, but can affect other parts too. When it comes to pseudo-gout, it almost always lasts more than 3 weeks, and it almost always affects your knee. Okay, so just those 2 points alone, just to delineate the two, is important, I think, to remember. Now, let's go into acute attack. If somebody comes in acute gouty arthritis and you want to treat them, what choices of treatment do we have? You have colchicine, NSAIDs, and steroids. Those are the three you're typically going to play with. Okay, all three are equally good. Okay, you kind of have to pick based on side effect profile here. If you're going to use colchicine, how much would you give first? What is the most dreaded complication of colchicine? It actually causes a myositis. Okay, you can actually cause a very painful myositis, and in fact, when you biopsy those patients' muscles, you'll actually, and the nerves, you'll see vacuolization within the nerves. So it can cause a very bad myositis. So those are your three drugs you're typically going to play with in your patients for acute flare-up of gout. Now, say you either have contraindication for any one of these three, or they're not effective, right? What do you do then? Do you have anything else that you can use? Because I told you to remember something. Yes, because when you had the needle go there, the macrophage released interleukin-1 beta, and the interleukin-1 beta was causing invitation to less of the neutrophils to come and damage the joint. So what if you block that interleukin-1 beta? What are the drugs? Anakinra and canakinumab. That's it. If you know this much for your acute management, you're golden. There's nothing more. Okay? Now, the next big question would be, okay, when should we give the patient chronic management? And when it comes to chronic management, what drug are we going to use? Thank you for watching. If you like our content, please like this video, subscribe to our channel, and hit the bell icon so you get notified when a video is released every week. Have fun studying. We'll see you on the next one.